increase in the overall death rate, because of which lobectomy was considered the gold standard treatment. But following almost a decade later, a group in Japan by Harada et al., they wanted to study the functional advantage offered by a radical segmentectomy versus lobectomy in lung cancer. 83 patients were present in this trial with T1N0 NSCLC, and they measured the preoperative 2-monthly and 6-monthly postoperative FVC and FEV1. And this trial showed that segmentectomy offered significantly better functional preservation as compared to lobectomy at both 2 months and 6 months. Following this, as an extension of the study, the Japanese continued to compare a segmentectomy versus lobectomy in small-sized peripheral non-small cell lung cancer. This was a landmark trial, the JCOB 0802, the results of which was published in the year 2020. This was a very large trial comprising of almost 1,100 participants, which was a multi-center RCT conducted between 2009 and 2014 for peripheral lesions less than or equal to 2 centimeter and a node-negative disease. This trial, the final results showed that segmentectomy showed a better overall survival as compared to lobectomy, which is 94 versus 91%. However, the segmentectomy group had a high local relapse rate of 10%, almost double that of the lobectomy group, which was 5%. The superiority and non-inferiority of the overall survival were confirmed using stratified Cox regression model. However, one of the major drawbacks of this trial was it compared only lobectomy versus segmentectomy, and it did not compare wedge resections. So this was the background for this landmark trial, which I will be discussing in detail, the CALGB 140503. Which was mostly conducted by the Americans, and they wanted to include comparison between a lobar versus sublobar resection for peripheral stage 1A NSCLC. The results of which was published in 2023 in NEJM. So regarding the definition of stage 1A in current practice, the TNM staging has evolved over the years. In the 7th edition, T1A was less than or equal to 2 centimeter, T1B was more than 2 to 3 centimeters, and stage 1A included T1A and T1B. Whereas in the current TNM 8th edition, T1 has subdivisions A, B, C, less than 1, 1 to 2, and 2 to 3 centimeter. And similarly, stage 1A also includes 1A1, 1A2, 1A3, up to 3 centimeter lesion. But the title says 1A. However, in the inclusion criteria, they have included only patients who had less than or equal to 2 centimeter lesions. So the inclusion criteria in CALGB trial was twofold. They had a preoperative criteria in which all patients, male and female, 18 years or older, with a peripheral lung nodule with solid component less than or equal to 2 centimeter, and with a tumor location located in the outer third of the lung, suitable for sublobar and lobar resection, with a good performance score of ECOG 0 to 2 were included. Following which, intraoperatively, they needed a biopsy-proven confirmation of non-small cell lung cancer, and also a confirmation of N0 nodal status by means of frozen section. For the right-sided tumors, nodal sampling was done from station 4, 7, and 10, and for the left-sided tumors, it was done from 5, 6, and 7. The exclusion criteria was patients who had received prior chemotherapy or radiation to lung, locally advanced or metastatic disease, a presence of pure ground glass opacities, and pathologically confirmed node-positive disease. So this was conducted between 2007 and 2017, which was a multi-center trial. Almost 83 institutes participated. International and randomized non-inferiority phase 3 trial. 697 patients were randomized into either a lobectomy group or a sublobar group. And in the sublobar resection group, around 59% underwent a wedge resection, and 38% underwent anatomical segmental resection. The type of sublobar resection, that is wedge versus segmentectomy, and the choice of surgical approach, which is thoracotomy versus VATS versus robotic assisted surgery, was left to the surgeon's discretion. The primary endpoint was disease-free survival, and secondary endpoint studied were overall survival, loco-regional recurrence, systemic recurrence, and FEV1 at 6 months post-operatively. So this is the general characteristics of all the patients in the group. And if you look at both the groups, the average most common tumor size was 1 to 1.5 centimeters, and the most common histopathological type was adenocarcinoma. Moving on to the disease-free survival, the graphs for both the groups are almost overlapping each other. So the 5-year disease-free survival in sublobar resection was not inferior to the lobectomy, 63 versus 64%. And similarly for overall survival, the 5-year overall survival was not inferior to lobectomy, 80.3 versus 78.9%. They did a subgroup analysis, and almost all the subgroups also showed no statistical significant difference between lobar versus sublobar resection, except for 3 subgroups. The 2 of them were based on the location of the tumor. The right middle lobe and the lingula kind of favored a lobar resection, probably because performing a segmentectomy in these 2 areas is technically more challenging. And the never smoker category also favored a lobar resection, probably because never smokers are found to have genetic mutations and most commonly adenocarcinomas, which are usually tend to be more aggressive. Moving on to the recurrence, 10 patients, that is 4 sublobar and 6 from the lobar group, who had died because of treatment-related issues in the first 90 days were excluded from this analysis. So apart from that, if you look at the loco-regional recurrence, it was 13% in the sublobar resection versus 10% in the lobar resection. And the distant recurrence also was kind of similar, 15 versus 16%. The 5-year recurrence-free survival was 70% after sublobar resection versus 71% in the lobar resection group. Moving on to the functional analysis, they measured the FEV1 and FEC at baseline versus at 6 months. If you look at the drop from the baseline for the lobar resection, it was 6%, and for sublobar resection, it was 4% for FEV1. Similarly, for FVC, it was 5 versus 3%. So the absolute difference between the 2 groups was only 2%. This 2% may not be significant in all the patients, but it is clinically significant in patients who already have a compromised pulmonary function or with patients in lower lobe disease. However, these were only a single measurement at 6 months, and 6 months single measurement is not predictive enough. And the study themselves suggested that these patients needed a 12 and 18-month follow-up to prove the significance of it. And moreover, there are better tests for proof of pulmonary preservation, like the 6-minute walk test and the pulmonary exercise testing. So both these trials, JCOG and CalGB trials, show that the segmental resection is better than lobectomy for peripheral 1A lesions. However, the JCOG trial included only anatomical segmental resections, whereas the CalGB trial included wedge resections also. And their argument was that it was more representative of the real-world scenario where most of the patients were undergoing a wedge resection. However, if you look at the distant metastasis published in both the papers, for the JCOG trial, it was as low as only 4 to 5%, whereas in CalGB, it was close to 15 to 16% in both the groups. The probable reason for this is JCOG study had a high proportion of part solid tumors, which are in generally having a better survival compared to completely solid tumors, which were included in the CalGB trial. So CalGB trial concluded that in patients with peripheral NSCLC with a tumor size of 2 centimeter or less and pathologically confirmed node negative status, sublobar resection was not inferior to lobectomy with respect to disease-free survival, and the overall survival was similar in both the procedures. Shall I move on to the next paper, sir?
No, I think they're completely different papers or subjects altogether. So
Yes.
it's best we start right now. Prashanth, comments, please.
So, this is one trial which has actually come out after a long time after the debate between, lobar resections versus sublobar resections. We all knew that lobectomy remain the standard of care. We have seen lots of loco-regional recurrences and mortality in any form of sublobar resections in the previous trials. Okay, so the positive, let's go with the positives of the trial. The positives is all these patients were randomized after a confirmed, N0 on negative on frozen. So that is something that which is very important to take. So you have to make sure that they were N0. All of these patients underwent a frozen section and confirmed that they were N0, and then they were randomized to lobectomy or sublobar resections. That is something that which you have to take. And the difference between this trial and the JCOG trial is that here even wedges were included, which you rightly mentioned. And there is a CT ratio which was also taken into consideration in the JCOG trial, which is actually not there on the, which was here, it was only solid part which was taken less than 2 centimeters, but whereas the consolidation tumor ratio was also taken into consideration in the JCOG trial. So they had more smaller tumors when compared to the wedge resection, so that's also one of the important things. But can we take it up as a tomorrow and say that we will be able to do wedge resections compared to lobectomy in all these? Yes, we have level 1 data as of today, but I think the data needs to, but the problem is, are we really ready? Is the question to go ahead and go with a wedge resection rather than a non-anatomical resection. The survival seems to be same, but in spite of that, the loco-regional recurrences were marginally, but then the survival is what matters, and then they're more or less the same. And you had actually mentioned one point regarding the technical challenges. Go back to the previous slide, please. So the right middle lobe and lingula are some of the easiest segments actually to do rather than technically challenging. So so lingula is something that if you want to do a segmentectomy, lingula is something that which is a very good segment to start off with. Yeah, middle lobectomy too, to some extent is also an easier lobectomy, but among the middle lobe, if you want to do in segments, then that would be difficult, but most of the times you end up doing a middle lobectomy rather than doing a segment in a middle lobectomy. So that is something that which you have to keep in mind. And I don't think smoking status is something that which really would have, whether you have to decide on lobar versus sublobar, which is something that though they might have shown, it might have not been a direct effect.
Yes, sir.
Yeah, George sir, your comments.
Yeah, I completely agree, Prashanth, on this. It's very tempting when you see the results of the study to say, and even the Japanese JCOG study, to say that for small lesions we'll do the segment or a sublobar resection. Now, to put it in perspective, the selection criteria of this trial are very stringent. So you have to find a peripheral outer third less than 2 centimeter lesion with negative lymph nodes on a frozen section. So very few patients are going to meet these criteria. Most of them have a hilar or lobar lymph nodes, which is a problem. Secondly, although it is not statistically significant, there was a slightly higher local recurrence rate in this trial, and in the JCOG study, it was actually double. So if you do, the overall survival was better and similar, better in the JCOG study and similar in the study. That is because they were able to capture the local recurrences and salvage them. Now, in an Indian population where your patients may not follow up so stringently with you, to detect a recurrence and salvage them is going to be extremely difficult. So on the face of it, although you find that overall survival is similar and local as in disease-free survival is also similar, I would hesitate to apply the results of this trial to the general population. So to me, if a patient presents with a peripheral 2 centimeter lesion, node negative, if the patient is fit, I would consider still a lobectomy. Now, I would be doing a sublobar resection only if the pulmonary function is compromised. The reason being that I find it extremely difficult to capture a local recurrence and salvage. This is based on the recurrence rates reported in both these trials. Incidentally, there was a questionnaire sent across to thoracic surgeons as to what they would subject themselves to, a sublobar resection or a lobectomy if they developed a tumor. And all the thoracic surgeons actually preferred a lobectomy because they were more concerned about the local recurrence. So I think the surgeons themselves, if it happened to them, would prefer a lobectomy over a sublobar resection. So all the results are encouraging of this trial. To apply it to the general population is a little bit worrisome. So I would say to the students who, in this group, that when you see a peripheral less than 2 centimeter lesion, please don't think of the wedge as a first option. It has to meet these criteria. If the pulmonary function is compromised, or if the patient is willing for a stringent follow-up, then probably you could consider a sublobar resection. And even in that case, I would say anatomical segmentectomy with the margins prescribed by the Jacob group, which is more than 2 centimeters from the tumor, etc., is a much more oncologically sound surgery than doing a wedge.
I have, for the interest of students, I have just put up the link to the European survey which was conducted. So if you're interested, please go through and read through that survey which Dr. George sir was mentioning. So that's something that which is very interesting. And being a surgeon yourself, if you would undergo, I think it was for a lobectomy. And that's a very interesting paper. And the advantages for students, you have all the references related to extent of surgery, lymph node dissection, everything available on that paper. So I put it up in the chat box for your reference.
I think, Soundarya, you can carry on with the next one.
Yes, sir. So the next paper is regarding the role of perioperative immunotherapy in resectable NSCLC. So just to give a background, initially there were many trials regarding the adjuvant chemotherapy, the one of which was the landmark LACE trial, which studied the role of lung adjuvant cisplatin. It was a pooled analysis involving around 4,500 patients, and it showed that the 5-year overall survival in platinum-based adjuvant chemotherapy was around 5.4%. And following this, the ASCO guidelines also included the adjuvant cisplatin-based chemotherapy for resected stage 2 to 3A NSCLC. Following this, there were other trials by the CalGB group also, which studied the role of adjuvant two-drug regimen, that is carboplatin with paclitaxel, and that also showed a statistically significant survival improvement in patients with tumor more than or equal to 4 centimeters. There were trials to study the role of adjuvant targeted therapy. However, unfortunately, the E1505 trial did not show any advantage of addition of bevacizumab, either in the overall survival or in the disease-free survival. However, in the year 2020, a landmark trial by the ADAURA investigators was published. This trial had 682 patients with resected stage 2 to 3A NSCLC, and they were randomized to get adjuvant osimertinib, which is an EGFR tyrosine kinase inhibitor. Adjuvant chemotherapy along with this drug was given in both the arms for around 60% of the patients, and this trial showed that there was an improved disease-free survival with osimertinib, almost close to 90% versus 41% of patients who didn't receive it, irrespective of the adjuvant chemotherapy. Following this, they wanted to stretch it a bit more, and there were trials comparing the role of adjuvant immunotherapy. Many trials were there. Only one of the trials, IMpower 010's results are currently available, which was published in 2021. Around 1,280 patients were randomized to receive adjuvant platinum-based chemotherapy, followed by a sequential atezolizumab, which is a PD-L1 inhibitor, for 16 cycles. This PD-L1 inhibitor was given only if there was a good response to the at least one cycle of adjuvant chemo. And this showed that improved 3-year disease-free survival in PD-L1 more than or equal to at least 1% expression in stage 2 to 3A tumors was around 60% in whom in those patients who received atezolizumab versus 48% in those who didn't receive it. And following this, the FDA also gave approval for sequential atezolizumab for completely resected stage 2 to 3A NSCLC with a PD-L1 expression of more than or equal to at least 1%. Similarly, there were trials for the neoadjuvant chemotherapy phase also. Initially in the year 2012, a group of from MD Anderson Lung Cancer Collaborative Research Group, they published this histologic response criteria to predict the survival of patients with resected lung cancer following neoadjuvant chemotherapy. And they gave two categories. One was a category of major pathologic response, which was presence of less than or equal to 10% of viable tumor cells following NSCT, and a complete pathological response where there is complete absence of any viable tumor following NACT. And these two groups, major pathologic responders and complete pathologic responders, were considered to be surrogate markers of improved overall survival. Following this, there were many trials, and one of the systemic analysis showed that there was an absolute survival improvement of 5% at 5 years. That is improvement from 40 to 45% in patients who had received neoadjuvant cisplatin-based chemotherapy. There were additional trials which tried to study the role of neoadjuvant immunotherapy. Many trials were there. Out of it, the landmark trial was Checkmate 816, which studied the role of neoadjuvant nivolumab plus chemotherapy in resectable lung cancer. And this trial showed that nivolumab was associated with an increased rate of pathological complete response, 24% versus 2.2% in patients who didn't receive it. It also showed an increased major pathological responders, 36 versus 9%, and an increased surgical completion rate of 83 versus 75%. So following this, the FDA approved neoadjuvant platinum doublet plus nivolumab for resectable NSCLC. However, all these trials had either studied the role of these drugs in the neoadjuvant phase or in the adjuvant phase. There was no trial combining both the treatment modalities. So that's when this trial, Keynote 671, which I'll be discussing now in detail, comes into place. This was conducted to study the role of perioperative pembrolizumab for early stage non-small cell lung cancer. The result was published in 2023 in NEJM. So this trial included patients 18 years or older with pathologically confirmed NSCLC stage 2, 3A and 3B according to AJCC 8th edition with a good performance score of 0 to 1. Patients who are considered resectable after surgical consultation and who had a sample for PD-L1 assessment. The lymph node involvement also needed to be confirmed histopathologically. The exclusion criteria was female patients who are pregnant and some tumor types and locations like the superior sulcus tumors, large cell neuroendocrine tumors, and sarcomatous tumors were excluded. And any patient with a known history of immunodeficiency state or history of pneumonitis or interstitial lung disease were excluded from receiving pembrolizumab. So this study comprised of 797 patients with an experimental and a placebo and a regular arm. The experimental arm received pembrolizumab 200 milligrams every 3 weekly, along with cisplatin or gemcitabine for squamous histology or cisplatin and pemetrexed for a non-squamous histology for up to 4 cycles, following which they underwent surgery. The R0 resection rate was 92% in the pembrolizumab group and 84% in the placebo group. And following the surgery in the adjuvant phase, pembrolizumab was continued for up to 13 cycles. The most common surgery performed in both the groups was lobectomy. The endpoints studied were, primary endpoint was event-free survival, which was defined as the time from randomization to the first occurrence of local progression that precluded the planned surgery, unresectable tumor progression or recurrence according to RECIST criteria, and also the overall survival. The secondary endpoints were the rate of achieving a major pathological response and a pathological complete response. So if you look at the event-free survival, the graphs are far apart for the pembrolizumab and the placebo group. In pembrolizumab group, it was close to 62.4% versus 40% in the placebo group. And the subgroup analysis which was done also, all the subgroups favored the pembrolizumab group. Pembrolizumab was favorable in squamous as well as non-squamous histologies. This is important to be noted because most of the other immunotherapy related regimes showed only a non-squamous histology featuring better outcomes as compared to squamous histology. The other benefit of pembrolizumab was the relative benefit in the group increased with increasing PD-L1 expression from less than 1% to more than or equal to 50% expression. Moving on to the overall survival, though the graphs were apart, 80 versus 77%, a statistical significance was not reached in the interim analysis of this trial. Moving on to the pathological response, a major pathological response was achieved in 30% versus 11% in the placebo group, and the pathological complete response was also significantly higher, 18% versus 4% in the placebo group. They did a subgroup analysis comparing the effect of pembrolizumab with the major pathological response which was achieved, and even here the pembrolizumab group, which had achieved a major pathological response, tended to do better than the other groups. Similarly, pembrolizumab group with a complete pathological response tended to do better than the other subgroups. Moving on to the safety and the adverse events, the grade 3 to 5 toxic events occurred in 44% of the pembrolizumab group, and most commonly it was nausea and neutropenia followed by anemia. The cause of treatment-related death in the pembrolizumab group, which occurred in 4 patients or 1%, was because of immune-mediated lung disease, pneumonia, and sudden cardiac death. What was to be noted was all these events occurred in the neoadjuvant phase and not in the adjuvant phase. The immune-mediated adverse events, which occurred in 25% of the patients, was most commonly hypothyroidism, followed by hyperthyroidism and pneumonitis. And this was noted to occur both during the neoadjuvant phase as well as in the adjuvant phase. Moving on to the limitations, immunotherapy is in general thought to be better functioning while giving in the neoadjuvant setting. This is because before the tumor is resected, there is obviously an increased antigen load circulating in the body, because of which there is an increased antigen presentation and increased priming of tumor-specific T cells, because of which the immunotherapy is thought to work better in a neoadjuvant setting. This study did not do a direct analysis of the relative contributions of neoadjuvant and adjuvant components of pembrolizumab. So probably an ideal study design would have been to include 2 more groups, in which one group pembrolizumab was given only in the neoadjuvant phase followed by a placebo, and another subgroup where pembrolizumab was given only in the adjuvant phase and the neoadjuvant phase received only a placebo. This would have been a better study design. So after all this, the group concluded that among patients with resectable early stage NSCLC, the neoadjuvant pembrolizumab plus chemotherapy followed by resection followed by adjuvant pembrolizumab significantly improved the event-free survival, major pathological response, and pathological complete response as compared with neoadjuvant chemotherapy alone followed by surgery. The overall survival, though the graphs were apart, it was statistically not significant in the group analysis.
Okay, so Dr. Soundarya, how would you like to dissect the trial and say that, okay, from tomorrow, are you going to follow this in your practice? We'll get your comments first before we give our comments.
No, sir. Purely because this analysis of whether the neoadjuvant phase or the adjuvant phase actually contributed to the benefit of pembrolizumab was not very established in this trial. So I would like to wait for an analysis on those lines. However, neoadjuvant pembrolizumab showed a very good major pathological and pathological complete response, which are markers of good overall survival. So based on that point, I will probably include it, but I will still wait for this subgroup analysis and before subjecting all the patients to pembrolizumab.
Okay. Okay. So, George sir, your comments on the paper, sir.
Excellent paper. Prashanth, you go ahead first.
Yes, sir. Sure, sir. So can you just go back to the few slides? So the most important, these two slides, the next two slides, please. Yeah, next slide. Yeah, this and this. So the most important here, one of the questions which has also been put up, so I'll take that question when I answer these. So one of the most important outcome that I would look at when you're actually giving neoadjuvant is not only event-free survival. I would also definitely look at overall survival too, as this thing, especially when you're looking at operable cases. When you have something looking at an borderline operable or you want conversion, then the pathological response and the operability, that is what I would look at in this. But having an event-free survival alone without an overall survival benefit, I would take the entire treatment category with a little bit of pinch of salt. Now the major question which always comes is, the pathological complete response always translates into better survival. This is what is something that which it's something that which goes on. But actually, if you see in this graph too, okay, so patients who had path CR when compared to placebo, the confidence intervals, if you see, have gone beyond 1. And there is actually not much of a difference in the outcomes in event-free survival. Yes. For those patients who have actually had path CR. So the confidence intervals going beyond 1 is something which signifies that there may not be much of a difference. This is something that which you have to really look into the graphs. But if you see the other one, probably pembrolizumab did better in those patients who were less likely to develop path responses. So this is something that which you really need to look. Even if you look at the other graph also, which is actually looked at the major pathological response, yes, that is also more or less similar. Okay, so I was actually trying to look at supplementary data on, have they done any, the question put forward by, was there any difference in overall survival? Probably there is no supplementary data. They might not have found any difference in the overall survival in the entire cohort. So it is less likely that you will get a complete, based on path CR, even in overall survival. Probably that's why the data might not have been presented. And mind you, the follow-up period is only for 24 months. Which sometimes is a little bit on the shorter side, according to me. And probably we may get overall survival in the due course of time, because it is said that immunotherapy responses seem to be sustained over a long period, and maybe longer we wait, we may have overall survival differences. So this is something that which I would, these are some of the critical points in the paper which I would look at it. And you got to take it, but I would, if you want me to use, I would use it for those patients right now who are less. And the drawbacks you very well pointed out, which were also given in the paper too. Sir, George, sir.
Yeah, I completely agree with what Prashanth said. So first thing, Soundarya very well presented and dissected paper, very good analysis. Now, exactly like Prashanth said, so pharmaceutical companies choose an endpoint which is easily achievable because the turnover time is shorter. If you look at overall survival as an endpoint, it is very difficult because you have a long waiting period. So they pick up surrogate endpoints which probably would reflect an overall survival. So you have recurrence-free survival, event-free survival, etc., which have a shorter timeline. Now, all this would be excellent in an advanced disease or a metastatic disease because you're going to give chemotherapy or systemic therapy for a long time. For an early stage disease, I think overall survival is the best endpoint because it's unbiased. So event-free survival as a surrogate in early stage disease, I'm not in complete agreement with. So like Prashanth said, it's only 24 months and the median survival was not achieved in the pembrolizumab arm. So probably there will be a supplementary or follow-up paper later which may show the overall survival. Another important point which Prashanth brought up and you also brought up was that the pathological response rate and the MPR was higher in the investigational arm, but it did not reflect in a change in the overall survival. Probably the adjuvant immunotherapy phase was given to take care of this. So it took care of the patients who did not respond well, and the survival is improved in those non-responders by continuing the immunotherapy in the adjuvant phase as well. So a lot of data emerging in the immunotherapy space. Most of it is neoadjuvant, as you said, because the presence of antigens, so they're more effective because of surgery. So that would be the preferred modality. Two important things which you have to notice in these two trials is earlier indication for giving neoadjuvant systemic therapy was an N2 disease. But all the new trials have included patients from stage 2 to 3A. So probably you are going to encounter more patients or giving systemic therapy in previously upfront surgically operable patients as well. Secondly, the discussion where N2 disease had become a non-surgical disease, especially with multicentric N2 disease, has now slowly become a surgical disease. Whereas, so you will find the newer papers actually mentioning as resectable stage 2 to 3A disease, which was not mentioned earlier. 3A was considered non-surgical in some. So you are finding that the surgical spectrum has increased. Multi-station N2 is being considered resectable. But earlier stage disease also may be subjected to neoadjuvant therapy. So you will find more and more data with neoadjuvant immunotherapy. But the caveat should be that we should look at overall survival as the endpoint. And I'm sure there is a follow-up paper which is going to come up, which may show it. Prashanth, any finishing comments?
No comments, sir. I mean, very well put up, because it needs to be taken up. So there is a question. So I'll from the chat box, we'll try and finish that also. So that's a question to you, sir. So post neoadjuvant chemotherapy, you see a clinical complete response and radiological complete response. So would you still go ahead and operate this patient, or would you choose to give CTRT as a part of organ preservation? Is what is the question. So what is your opinion and take on that?
Yes. So it's a very interesting question. This is a question which is raised by patients quite often when there is a response. Unfortunately, in this scenario, there is no evidence from any of the trials where you would switch therapies and go for radiation. Now, if the patient is scared of surgery and refuses surgery, that's the only situation where I would consider radiation at this point, because there is no evidence to support it. Now, the absence of a radiological presence of disease does not mean that there is no microscopic disease there. This is something which we find very often in resected specimens. So I would go ahead and resect these patients.
I completely add on to that, because radiotherapy is also associated with complications. It is not complication free, mind you. So it's not that somebody is receiving CTRT doesn't mean that they do not have complications, or and when you don't have a lesion, actually the amount of normal lung that is going to be exposed to radiation. So I would actually prefer to do surgery. I mean, we don't have data, but I would prefer to do surgery. The concept of organ preservation has not set in, because your lung function would still be deteriorated in spite of. And now lung surgery is a safe surgery, unlike 2 decades ago, where the morbidity and mortality was much higher. But I think now with minimal invasive procedures coming up, the data is something. The morbidity is quite acceptable in terms of these surgical outcomes. That is one thing. And the other thing which the paper did not also mention is the complexity of the surgery. Though there were not much mortality, post immunotherapy, there seems to be some challenges for the surgical technique for minimal invasive surgery. So that is something that which would actually was not mentioned very clearly. But the outcomes, the morbidity, the mortality was more or less similar in both the groups.
Also a question in the group where even an N3 disease, N3 is a non-surgical disease, and you would consider it only in a salvage situation. So here also, when they mention N3, they do not mention N3. They mention 3B, which is an N2 with a higher T stage. Okay, so none of these trials include N3 or unresectable disease. They are talking resectable. If you look at inclusion criteria, it's all in resectable disease. Now, the trial which included unresectable disease or N3 is a Pacific trial and the follow-up trial, where chemoradiation was given, followed by durvalumab. So the question which is being addressed in this question is resectable N2 disease, not N3. And surgery would be considered in an N3 situation only as a salvage strategy. And there's also a question on N2 disease post neoadjuvant chemotherapy. How do we go ahead? Now, that's a highly debatable question. If it is post-neoadjuvant chemoimmuno, I would definitely say go in for surgery because that's a planned strategy. I would say most of the decisions regarding surgery should be made before induction chemotherapy or induction chemoimmuno should be given. Now, 50% of surgeons across the world in resectable N2 disease post chemo induction chemo would consider surgery. Some would do redo mediastinal staging, and in view of persistent N2, they would say poor prognostic criteria and give chemoradiation. Highly debated issue. There is no perfect answer to this. You would find a 50-50 split anywhere in the world. Prashanth, you want to add to that?
No, I completely agree, sir. Completely agree. I mean, if it's something that this is a decision that it has to be taken, but if it's chemoimmuno, even I would do the same. So there's another interesting question. Would you ever do a sublobar resection following chemoimmuno or post NACT rather than doing a lobar resection? Initially, the lesion was stage 2 and above, and now very good response, confined to apical segment or probably basal segments. Would you ever consider doing sublobar resections?
So even in a chemo-naive patient, I am highly reluctant to perform a segmental resection for the reasons I mentioned after the previous paper discussion. If you notice the inclusion criteria in the previous paper and even the Jacob trial, it's very strict. Peripheral less than 2 centimeter lesion with a chemo-naive. That's an inclusion criteria. So segmental resection is not appropriate for a disease which required neoadjuvant chemoimmuno, because automatically it implies a higher T stage and a higher N stage, and a segmentectomy would be an inappropriate surgery for it, unless, of course, the pulmonary function is prohibitive and you are not able to perform a complete lobectomy. But I would say upfront, not the appropriate choice.
Right, sir. Yeah. Okay. So can we move on to your next paper, Dr. Soundarya?
Yes, sir. So the third one is regarding the role of surgery for oligometastatic NSCLC. Unfortunately, I didn't get complete access to this paper. I'm extrapolating data from the abstract. To give a background, the definition of oligometastatic NSCLC itself is very variable among many groups. The ASTRO defines it as the presence of 1 to 5 metastatic sites, whereas the American Radium Society defines it as 1 to 3 sites, and so far there have been no randomized control trials regarding the role of surgery in oligometastatic disease. So this is one abstract for the role of surgery for primary tumor in the surgery for primary tumor is associated with prolonged overall survival in patients with oligometastatic NSCLC, which was published in 2022 in the Journal of Thoracic Oncology. So this was a single institute observational cohort, which included patients with synchronous oligometastatic NSCLC, and they had included a definition of up to 5 metastatic lesions, who had received multimodal treatment, including surgery, for primary lung tumor between Jan 2010 to December 2020. The endpoints studied were primary endpoint and secondary endpoints were the received it. And regarding the surgery for the primary, lobectomy was done in 21 patients, and pneumonectomy done in 4 patients, and sublobar resection in 2 patients. And R0 resection was achieved in 85% of the patients. The morbidity associated with the surgery for the primary was around 33%, and the mortality occurred in 3% of the patients. Median overall survival was 77 months. Another analysis that they tried to do in the study was they tried to measure the preoperative and postoperative serum CE CEA levels, and they try to analyze the role of increased CEA in providing a better overall survival. So this is the CEA level at diagnosis. And the median overall survival in patients who had a normal CEA level at the time of diagnosis, which is this blue line, was significantly higher, 84 versus patients who had a high CEA level at the time of diagnosis, 54%. And similarly, CEA level post-operatively was also measured, and in a group of patients who had a normal CEA post-operatively, which is the blue line, significantly tended to do better as compared to a high CEA level, 80 versus 44.5. So based on this, they concluded that surgery for primary tumor is associated with a prolonged overall survival in patients with oligometastatic NSCLC, and the CEA level could be considered as an important predictive factor for overall survival and patient selection that requires further research.
Yeah, I mean, very well presented, Dr. Soundarya. This is actually only in the form of an abstract, and the full paper is not out. But I think we have other data to show that a local consolidated therapy in oligometastatic disease does improve outcomes. So not much comments on the paper, but yes, in oligometastatic disease, definitely there is a role for local consolidation, local consolidative therapy, and to improve outcomes.
Yeah, yes, completely agree. So for the students out there, this is a scenario where oligometastasis, that is a limited number of metastases, up to 5 in 3 organs, is something which you're going to encounter. It could be at presentation at some point during the surgery, or a multiply metastatic disease which has responded with some persistent mets in one location. So in this era of targeted therapy and immunotherapy, you're going to find that even there is actually a trial going on in Europe, where in metastatic disease also they give systemic therapy, and at the end of it you find limited metastasis. So these are also oligomets and might be amenable to surgery. So important thing to decide in this treatment, either in a local consolidated therapy in the form of radiation or surgery, is possibly a good option. Improve survival as per a randomized trial. I put the link on the group, Gomez et al. Major thing is it needs a multidisciplinary team. You shouldn't jump in and operate limited metastasis. If you see it, discuss with your medical oncologist and radiation oncologist. And if you think it's local consolidated therapy will help, please go ahead. It could be either surgery or radiation, depending on the site. So if you have a bone met, probably radiation. Brain met, debatable, radiation or surgery. And if it's an adrenal or any other site, probably surgery would be a better option. So always important to discuss in PT. There is a randomized trial which has shown a benefit in this scenario. You are going to find increasing number of patients, especially with persistent or oligo progression in some metastasis, and you might have to tackle that with local consolidated therapy. And I'm sure it's going to improve the survival, but key is a multidisciplinary team. No point in jumping the gun and doing the treatment on your
own. So we have a question from Dr. Jagannath Dikshit, sir. So for small lesions that are not peripheral, how do you go about localizing these lesions for minimal invasive surgery? Any experience with wire localization or intraoperative ultrasound localization?
So I've used both. What I normally place is a wire, Cook's needle, placed with IR guidance, that a CT scan done on the morning surgery, and the wire is placed with the lesion. And most of the times I go in for a wedge excision of that tumor. It's usually done for metastasis. For deeper seated locations, lesions, for NSCLC, I do not advocate this technique. But if it's a metastasis deep seated, not palpable, I would put a guide wire placed with a CT scan. I have tried ultrasound and resected a couple of tumors, but it is unbelievably difficult because the air interface in the uncollapsed lung, it's quite difficult to find. You're guessing at most points. So my experience with ultrasound is limited and has not been very satisfactory, although we got the lesions out. It was not a very convincing result. So guide wire is hook needle is what I would prefer. Your experience, Prashanth?
Sir, most of it is only wire localization, no experience with ultrasound. Actually, just a few days back, we tried ultrasound, but it's actually challenging. The lung needs to be completely collapsed. If you have slightly bigger lesions, central lesions, it's okay. But otherwise, it's we actually couldn't make out the lesion very well. We were not convinced. So I converted and then palpated and then took it out. So there's an interesting question, oligometastasis with N2 disease. So if you have an oligometastatic with N2, does your nodal extent really make a difference in choosing these patients for surgery?
It's a very good question. So we actually put up a paper sometime back on 9 patients which we had done, 9 or 10 patients which we had done with oligomets. In all of them, because of some data which had come from a Russian paper, we had excluded N2 disease by mediastinoscopy before addressing primary and the lung lesion with surgery. So N2 disease is initially excluded. It is an extremely poor prognostic factor. But with the current progress in systemic therapy, you will see that most of the recent papers include N2 disease as well, along with oligomets. So they are no longer a contraindication for resection on oligomets. Earlier they were.
Okay, so I think that answers the question. If I see no other questions in the chat box or in the Q&A session. So, Dr. Soundarya, you have any questions?
No, sir.
No. Okay. Thank you. I mean, actually, very well presented. All 3 papers, Dr. Soundarya. I mean, a lot of effort has gone into being out, and a good literature search. A good background literature search that's what actually makes the journal clubs to part of. And that's one positive thing in your presentation. You've done a good literature search and then taken the paper across. So thank you, and Sir George, sir, over to you, sir.
Thank you very much. I thoroughly enjoyed the presentation. Soundarya very well presented and dissected. The analysis was pretty spot on. So a good job. I hope you carry on with this forward to your exam as well, because it reflects the quality of work which you have put in. Thank you very much to all the people who are listening in, because very interesting questions have come up. Some of them are complete googlies for which both me and Prashanth don't have an answer at all. But I'm sure time will be more data emerging from this. I hope the session was informative for you. If there are any questions, of course, you can follow up in this forum or text us personally. We'll be happy to resolve any of them. Thank you very much. And thanks, Som and Navneet, for organizing it. It's been amazing. The system is amazing. It's a wonderful experience. Thank you very much, guys. Navneet, over to you.
Yes, sir. Thank you very much, trainees and faculty members, for joining the session. Thank you.
Thank you.
Okay. Thank you.
See you, Prashanth. Bye. Thanks.
Bye, sir. See you, sir.